The goal of my talk is to kind of introduce you to a topic that I think is really very important in not only myasthenia gravis, but really in any disease. And it's hard to imagine that it's actually been about 18 years now since the first 13 years now since the first biomarker congress took place. So people have been looking at biomarkers for a very long time, but in other diseases, I think from a myasthenia gravis standpoint, we're sort of late in the game. We've all heard the biomarkers that are available for cancer. We're hearing about the biomarkers available for diabetes mellitus and so forth, and now even biomarkers available for Alzheimer's disease. But for myasthenia gravis, it's very limited. And so the bulk of my research over the next few years is really going to be centered on that. So let me tell you a little bit about what biomarkers are. So importantly, biomarkers are medical signs that are measured accurately and are very reproducible. And it's important that we know that they can be reproduced. There's got to be consistency present. And you probably have had biomarkers already, and you don't realize it or really don't think about it. When you go see your doctor, one of the first things they'll do is they'll take your blood pressure and pulse. And so these are biomarkers that we follow, especially if you have high blood pressure, for example. Those are all things that your physician is looking at. But there are several other biomarkers. There are biomarkers that we test for in the blood. So for example, if you have an infection or are on immunosuppressive therapy and you're needing to be followed for white blood cell count, simple blood test of white blood cells to tell your doctor what the number is a simple biomarker that is done. Then there are others. Many of you may be familiar with the famous pulmonary function studies that are out there, and I tell you, it's a very difficult test, and you know, many of my patients tell me that it's a very enclosed area. Oftentimes they have to sit upright, and there's not a whole lot of support for that, so it can be a very challenging test to do in some of you, but it is also a biomarker. It's very reliable. It tells us how your breathing is doing, whether or not it's declining, whether or not you might need BiPAP intervention, etc. And then there are imaging studies, and probably the better ones known are for cancer and for Alzheimer's disease. And as you can see here, this is a PET scan. This is one patient that is completely normal. And then here we have an abnormal scan in someone who's got Alzheimer's disease. So again, these are kind of signs, medical signs that we can sort of tell us what is going on in the disease itself. Now, there are different types of biomarker types. We've got biomarker types that are used for diagnostic purposes. So in myasthenia gravis, we have the acetylcholine receptor antibodies, we have MuSK, LRP4, anti-titin, etc. Other things, other biomarker types are those that are used for prognostication. So in glioblastoma multiforme, or one of the most serious types of brain tumors, having MGMT methylation will tell us whether or not you'll respond to a certain type of chemotherapy. Likewise, in a condition known as Guillain-Barré syndrome, where people are paralyzed and in an ICU, we know that the younger you are, the better you do. So those are examples of prognostic or biomarkers. Then we have biomarkers that are predictive, and they'll tell us what may happen. So we know that individuals who are overweight or obese can, and especially if maintained, have a very high risk of developing diabetes mellitus type 2. We also know that individuals who have high blood pressure or elevated levels of homocysteine level may be at very high risk or can predict that you will have a stroke. And then last but not least, we have biomarkers of the type that sort of predict or give you a pharmacological response and allow us to monitor the disease. Examples of this include in diabetes, we have something called the A1C, and if any of you have diabetes, because of the steroids that we've given you, you know that this is something that many of your doctors look and follow and are on you all the time to make sure that it stays as low as possible. Then in cancer, the PSA, the gentlemen out in the audience are probably familiar with this particular test. So you can see that there are various different types of biomarkers. In myasthenia gravis, primarily we have these for diagnostic purposes, so we're lacking these. Now, what are the current biomarkers? And just as a quick review, I think all of y'all are familiar with these. We've got the acetylcholine receptor antibodies, the 3 types, which kind of attack the postganglion membrane. Then we've got other types like MuSK, also affecting the postsynaptic membrane. Got LRP4, Rapsin, Titin antibody, striational antibodies, which are really elevated in individuals who have thymomas or cancers of the thymus gland. And then last but not least, I throw this in here as a sort of biomarker, if you will, the single fiber EMG study. If any of you have had those done to help your physician diagnose myasthenia a little bit better. It's not specific for MG. It is very specific for abnormalities in the neuromuscular junction, but very important. So we do have some biomarkers, but I think we've got a long ways to go. Now, you've heard a little bit about treatments that are out there, and many of you are familiar with the ones I have here on the slide. We've got Mestinon or pyrrostigmine bromide, which is acetylcholinesterase inhibitor. We've got the corticosteroids, which probably most of you have taken at one point or another. It is felt to be one of the best, if not the best drug for myasthenia gravis. Then we have several immune modulators, including Imuran, cyclosporin, Cytoxan, methotrexate, and then we heard a little bit in the talk earlier today about mycophenolate mofetil. We've got the monoclonal antibodies, rituximab, which is very good. Solaris also, which is coming to play now. And then we've got IVIG. There are some studies looking at it instead of being given intravenously, given it subcutaneously, which would be wonderful because you could have this done at home, and there may be a few of you in the audience who have tried this. Plasmapheresis, of course, which is wonderful, and really the only treatment that we can use when patients are pregnant. And then we've got thymectomy, which if you're acetylcholine receptor antibody positive, I think many of us are now trying to encourage you to have the thymectomy. So we've got wonderful treatments, sort of. Many of these treatments, as you all well know, have many side effects. And that's the problem. Treating a disease is one thing, providing treatment and quality of life is another. And that's sort of my interest in myasthenia, because we know in right time with right therapy, eventually you will improve. Eventually your symptoms will get better. But we don't know what your true quality of life will be. Many of you will be able to return to some, quote, new normalcy where you might be able to work part-time or you may be able to have families, but some of you will not. Some of you will remain on permanent disability. And trying to sort of figure out which direction you're going to go and what you might respond to becomes very important. I like to show this slide because, as you can see, at the early 1900s, the death rate of myasthenia gravis was very, very high. At the turn of our century here, as you can see, it's dropped significantly, and if we follow this out a little bit more, it's not quite zero, but almost zero. So with the therapies we have been able to really significantly cut the mortality rate. We've gotten a little bit better at diagnosing you, but the morbidity, the problems that are associated with treating you has really not changed. That line did not show up well on that slide. But here are sort of the issues that come up with the therapies, and I'm sure that most of you at some point could probably relate to that. So, definition of futility, doctor asks that I take prednisone at a higher dose and is asking me to lose weight. I mean, on the one hand, yes, we're going to help you, prednisone's going to make you better, but on the other hand, lose weight. Well, guess what? Prednisone really is not conducive to you losing much weight or makes it very challenging. Just because I don't look disabled doesn't mean I'm not. And all of these things, by the way, are things that patients have told me at one point at time during their disease. So many of you you go into a meeting, you see family and friends, and guess what? You look great. I mean, I see all of your faces, and you look wonderful. But no one can understand what you go through because it doesn't show externally. No, it's not like if you had Parkinson's disease where patients are shaking, or they not smiling, or they're obviously having problems speaking. You don't see myasthenia easily. Or this one, look out everybody, I'm going to be crabby for the rest of the day. Doctor told me to double up on the prednisone dosage, and so forth. I think the one that really touched me the most was this one, I want to live, not just survive. And that's what we're seeing. I mean, I think we've made an incredible amount of progress in being able to treat you, in being able to kind of get you out of the crises, out of exacerbations, at least for periods of time. But we've not been able to give you back the life. And this is what we need. Truly to start focusing our research and expanding our research on. And then this one, as probably many of you have experienced, many of the therapies that are out there are wonderful in helping you with minimizing double vision, helping you speak better, swallow better, etc. But fatigue remains a very big problem. And I've polled many of our patients, and probably the number one thing they wish that could improve is the fatigue, because even when they have a little bit of double vision, or they're not able to speak well, or they're having swallowing problems, they have been able to kind of adapt to that, if you will. But the fatigue component is not something they can adapt to. It's very, very hard. You know, most of you are very active, or were very active individuals before you became ill, and so having to contend with that fatigue is a big problem. So I put this slide up. It's a very busy slide, but I just want to kind of send the point home that indeed we've made progress in cancer. And I put breast cancer up here, but we could easily use lung cancer, we could use prostate cancer, et cetera. But what we're seeing here is that there are various sort of biomarkers that are used in individuals to be able to predict or to say who's at risk for it. I mean, if you have BRCA1 or 2, that's been out in the news quite a bit, and you may have family members or you yourself may have this gene, you know that you're at risk for cancer, and so preemptively, even before you have cancer, as early as in your 20s, you may go to your physician and say, I've got this gene, and they will tell you what the therapy or what needs to be done. We don't really have that for myasthenia. We have some genes that we know may sort of put you at higher risk of developing MG, but these genes are not specific for MG. You may see these with other autoimmune diseases, and you know, where there's one autoimmune disease, there's another. They usually go hand in hand. So we don't have anything that is specific to MG. So one of the things that we're wanting to try to identify is what genes do you have that put you at risk for developing MG? And can we get these genes sort of monitored, or can we test these genes as part of a routine physical? The cost of genetic testing has dropped down dramatically, and now there's even tests that you can do through the mail that are, I think, $200 or so, that identify certain genes, and they come back to you. And so I think the time has come for us to be able to get a little bit better of an understanding of what genes exactly say, hey, I'm going to develop myasthenia. Then screening tests or biomarkers, we really don't have anything compared to breast cancer patients. We don't have any labs, nothing that we can do to say, hey, you're starting to develop MG early, or that's the first sign of MG. We have our clinical exam, and we have you, educating the public at saying, hey, if you develop a droopy eyelid, if you develop double vision, that indeed this may be a sign of myasthenia, go see a doctor. But, the reality is that most people don't know that, and even in the best of hands, many doctors are not familiar with myasthenia or the symptoms, and so there may be a delay delayed period. So it'd be, we really need to work on that a little bit better. We're great in diagnosing that. As I said and showed you earlier, there are many labs that we can do to make the diagnosis of myasthenia, although we've got a way to go. I will admit it's not perfect because there are seronegative MG patients. Then prognosis, we have a way of telling a breast cancer patient, you are going to do so well, or in 5 years we expect you to succumb to your disease, et cetera. We really don't have that for myasthenia. We really need to work on being able to say, hey, if you have biomarker X, most likely you will go into a crisis. If you have biomarker Y, most likely you will not go into a crisis, and so on and so forth. And then, as you can see here on the slide, and I do apologize, I'm having a little bit of a difficulty kind of seeing that from this angle, but you can see that monitoring the disease is fairly easy here in breast cancer. There are several markers, including CEA, which is pretty common, although not specific for breast cancer. As far as monitoring your disease in MG, we really don't have any. There is a lot of controversy as to the role of acetylcholine receptor antibodies, or any antibody for that matter, and how it correlates with disease. There are some studies that show that if you have a very high titer as an individual, that means that your disease is very active, but then you put groups of individuals together, and that sort of relationship does not exist. And so we need to find markers that tell us, hey, your disease is in remission, or it's going into remission. The clinical exam is wonderful for that, and you might ask, well, if the exam tells us, well, what's the point of having a biomarker? Well, I hope you've not found yourself in this situation, but I've had the occasional patient that will see me on a Thursday or Friday, and I get a call on Monday morning, and they were fine Friday. They were doing beautifully, so much so that I started lowering the prednisone, and something happened over the weekend, and Monday morning I get the call, I'm not doing well, and they're heading for the emergency room because they're in an exacerbation. So although exams are great, it's not 100%, and so having a biomarker that might be able to tell us, hey, this is about to happen or this may happen would be wonderful. Some of the things that I'd like to kind of address in our session, and more importantly in the research that we have going on, is some simple questions, and that is, why do some of you respond to some therapies and why do some of you don't? So going back to the issue that prednisone is very helpful, there are people who don't improve with prednisone. There are people who don't improve with Mestinon. And as wonderful as Rituxan is, there are some of you that no matter how many times we give it to you, you still don't improve with Rituxan. So I think a very basic question is, what would be a biomarker that allows us to tell us what response will be? Why do some of you take longer to improve? So why is it that some of you respond the first time we give you IVIG, and then there are some of you that take a year or two before you start improving? Another question or concern is, why do some of you have a crisis and others never have a crisis? And if you've ever had a crisis, it's probably one of the most scariest things that can ever happen. And when you see that fear in your patient's eyes, that they're going to have to be intubated or that they're going to have to spend a week or two in the ICU, it's very, very scary. And being able to find a biomarker that would tell us from day one of diagnosis that, hey, you're at risk for that, might allow us to treat you more aggressively to prevent a crisis from happening in the first place. Why do some of you go into remission and others don't? And then what factors lead to progression of disease? We know that stressors, infections, medications, et cetera, cause exacerbations. But we don't really know what leads the progression of disease. So why do you go from having only eye involvement to suddenly having your muscles that allow you to swallow or speak involved? Or why do you go from having only involvement in your arms or breathing muscles to having problems with speech and swallow? So these are all sort of questions that need to be addressed, and that hopefully through some of our research we'll be able to address it. Now the next set of slides are sort of giving you a little bit of background on the science of it. And they're very busy slides, and I put them up there simply to kind of give you an idea of how complex our immune systems are. When we talk about autoimmune myasthenia, whether acetylcholine receptor, positive, negative, LRP4, MuSK, what have you, we're talking about a dysregulation of the immune system. On the one hand, we've got an immune system that is overly active in some areas, and then on the other hand, we've got an immune system that is underly active. And that balance, that check and balances, if you will, is lost. Normally, our immune systems are able to keep us in check. That's why we don't get sick. But people who develop autoimmune disorders, for reasons that we're still trying to understand, lose that sort of self-regulation, if you will. And when they lose that self-regulation, they start developing myasthenia or lupus or rheumatoid arthritis or Hashimoto's, etc. So the main players in myasthenia are our lymphocytes. And you've probably heard the white blood cells that come in, are made in the bone marrow, or the stem cells at least are made primarily in the bone marrow. But there are two main types of white blood cells that are very important in myasthenia gravis patients. And these are the B cells, and then we've got the T cells. The B cells are cells that actually, for the most part, grow, develop, and mature in the bone marrow, and then leave to outside organs. The T cells, for the most part, are cells that are actually, their stem cells are made in the bone marrow, but then they travel to the thymus. And it's very important to remember that traveling to the thymus is where they grow up. Okay? Remember that we're doing thymectomies on patients, and so perhaps there's a relationship there. So these T cells, if you will, and there are various types of T cells. There are T cells that are meant to kill certain things in your body. There are T cells that help the B cells mount an immune response. And then there are T cells that kind of regulate all of that. And it's the balance of those cells between each other that allow us to stay healthy. In myasthenia gravis, what we have is the T cells training, if you will, in the thymus gland. Now, just to refresh your memory, the thymus gland sits right here in our chest. It's right beneath our sternum, our breastbone, just a little bit above the heart and in between the lungs. And this is sort of a depiction of the thymus gland here. It's actually a very, very small gland, but it's got two lobes, a right and a left. And if you take it a little bit further and look at it from a histological standpoint under a slide, the thymus has two main parts to it that are important. It's got the outer layer that we call the cortex, and then we've got the inner layer called the medulla. And normally, in a normal, healthy thymus, this is sort of what happens. You have sort of the cortex and the medulla area of normal size. You've got a couple of areas in between the two, these dots called germinal centers, where occasionally the B cell, the other player in this game, comes in and sort of gets challenged and may grow up, and maybe it changes its receptors, what have you. In myasthenia, this is what we see. We have an enlargement of these germinal centers. And this is important because normally B cells don't come to the thymus a lot. They may come occasionally to visit, but they don't come and stay. And in myasthenia gravis, they come and they stay. And they stay and they grow and mature and develop, and then they leave. And when they start leaving, they create these antibody responses that lead to myasthenia. Very quickly, the antigen or the substance that these B cells and T cells start to react to and sort of all of a sudden say, hey, I don't recognize you, and lead to an immune response are these myeloid cells. The myeloid cells are very similar to our muscle cells that we have in our arms and legs and skeletal muscles. And it's the presentation of this myeloid cell, the way it looks, the way it behaves and it functions, that causes our immune system, our immune cells, specifically the T and B cells, to mount an immune response. So, put another way, if we got rid of all of our myeloid cells in the thymus, most likely we would not have at least acetylcholine receptor positive myasthenia gravis. We might have other things, yeah. But you know, the thing about the thymus, it's a very interesting story in the sense that the thymus gland grows and reaches probably its maximum size at about age 10. From that point onward, it just starts getting smaller and smaller and smaller. And even in patients who have myasthenia gravis, if we go back to this slide, even when you find something like this in their thymus in a 50-year-old or a 60-year-old, outside, the exterior of the thymus actually is not that large. So it actually is important in developing the immune system early on, but as time goes on, you really don't need it because you've essentially trained the cells. So going back to the T cells, and the T cells go into the thymus, and think of the thymus as a training camp, if you will. If you think of them going to try to join the Marines, I have a nephew who's actually joining the Marines, and so I use this analogy. These T cells are born, the stem cells are born in the bone marrow, and then they leave. They have to grow up. They have to mature. They have to get a job, if you will. They have to start playing a role in the immune system. And the way they do that is they go to the thymus gland. And in the thymus gland, there's a series of events that happens, and I'll show you that here in a second, where they go from being very immature, so, essentially being 18, to suddenly being 24, 25, and hopefully having a job and being all grown up. And it's not easy. There is natural selection in the thymus gland, and really what happens there is that those that just don't make the cut don't make it and get kicked out, and they either die or they become other types of cells, what we call T regulatory cells. And those are the cells that help us keep our immune system in balance from being pro-inflammatory to anti-inflammatory and going back and forth. So what are some of the markers or biomarkers that might be playing a role and that we might be able to study to look at their effect in MG? Well, it stands to reason that if the thymus gland is a training camp for the T cells are heavily involved in myasthenia, and the thymus, when removed, helps many patients who are acetylcholine receptor antibody positive go into remission. Maybe there's something in the thymus. Okay? And the thymus is an endocrine gland. It's very much similar to the thyroid, to your pituitary, to your pancreas. It secretes hormones. And believe it or not, these hormones are very, very important in helping us in different things, in day-to-day things in life, including pain, including the ability to stay awake, etc. So one of the substances that the thymus secretes is something called thymulin. And thymulin is a substance, it's a hormone really, that has an effect on T cells in this way. It helps not only help them grow up, but it also helps specify them. So it takes them essentially from going into boot camp to essentially becoming officers, if you will. It is very dependent on how much zinc you have, and so one of the things that we're looking at is what is your zinc level in the blood at the time that you're diagnosed, or what is your zinc level at the time that you go into an exacerbation or crisis. Because without zinc, this hormone, thymulin, will not work well. We do know that when you're younger, under the age of 20, the thymulin is at its highest, and after that age, it falls. And by the time you're in your 60s and 70s, it's almost non-detectable. So thymulin is one of the substances we're looking at as a potential biomarker. Now, to show you just a little bit in a different perspective of how thymulin works is if you look here, this is a T lymphocyte or a lymphoid cell, if you will. It's very immature. It's coming directly out of the bone marrow. It's coming here into the thymus gland, and it goes through several steps here. The important thing is that it becomes very mature, if you will, when it goes from step 1 to step 2. And in this phase here, it's where you actually go to boot camp, training camp, and those of the cells that actually can't pass the physical or who can't run the mile or can't fulfill those basic requirements get kicked out. They get booted out. Many of those cells will die. and go on and get excreted from the thymus, and some of those cells, as I said earlier, will become T regulatory cells. Then step 2 is where they become specialized, and this is where a lymphoid or T cell will say, hey, I'm going to be in artillery, all right? I'm going to be direct defense. Or they become cells that are going to be on the infantry. But more importantly, once that sort of concept is made, or once that decision has been made, they become officers. So they go directly from being infantrymen to being officers. Very, very specialized. And when they are specialized, then they leave the thymus gland. So we don't have time to go over all the other fine sort of things that happen, but suffice to say that without thymulin, this won't happen. Too much thymulin, too much of this happens. Too little thymulin, too little of this happens. And so once again, we're disrupting that balance between the inflammation, the pro-inflammatory substances and anti-inflammatory substances. Now, as you can see here, and as I alluded to earlier, thymulin is not just affecting the thymus. Thymulin actually affects several parts of our body, including the central nervous system, the brain. It has an effect on the pituitary gland that secretes other hormones. It actually now is known that it has an effect on pain. And there are subsets of patients with myasthenia gravis who have pain, who have neuropathies, and we don't know if it's because of a dysregulation of thymulin that is noted, or if there's something else, but it could be. So it doesn't only affect the immune system, it affects the central nervous system, and as I said, also it affects the endocrine system. So a very complex hormone substance, if you will, that we need to look at and study further. But I think because it is so complex and it does so many things, it's a very strong candidate for being a biomarker of disease. Another player, another substance, hormone, if you will, that is secreted by the thymus is thymosin alpha-1. And thymosin alpha-1, again, it's a complicated slide. I apologize for that. But suffice to say that it does two things. It has a direct effect on the immune system in trying to actually kill or ward off, if you will, viruses or infections. And bear in mind, we don't know what causes MG. We know that maybe most patients have some gene that predisposes you to an autoimmune condition. But why do some of you get it when you're 20? Why do some of you get it when you're 5? And then why do some of you get it when you're in your 80s? We don't know. But we think there may be environmental factors like viruses that might be playing a role. And again, so studying something that might affect that part of the immune system sort of makes sense. And so one of the things that thymosin does is that it actually has a direct effect on the cells that may cause illness from viruses or cancer, et cetera. It also has an indirect effect, and it has a big role to play in not only developing and maturing the lymphocytes, the T cells and B cells, but it also causes them to proliferate and to replicate, and they in turn secrete different substances that has an effect on the immune system. So thymosin is another hormone that we're looking at. Thymopoietin is another substance that is secreted by the thymus gland. Like some of the other ones I've mentioned, it does have an effect on T cells. It stimulates the differentiation of T cells, so this is where, again, they become officers. They select what type of specialization they're going to have. Interestingly enough, it prevents B cells from becoming specific, and that's really important because in myasthenia gravis, it's when this differentiation occurs that all the antibodies get produced, and as the antibodies start getting produced, you become ill and present with disease. So this may be not only a biomarker of disease activity, but it also could potentially be used for a possible therapy. So it does several other things. It increases interleukin-2, which is a main player in the immune system, and it also increases the receptor for interleukin-2. Interestingly enough, there has been some work already done on this. And in fact, when I started looking at biomarkers and hormones in the thymus, I found very little research done recently, i.e. from 2005 onward. A lot of this research was carried out in the late 60s and early 70s, and somehow it got lost. There was some research that began in the early 90s and then again kind of dropped off the radar. But they have shown, they've done experiments looking at thymopoietin, and they have found that it is increased, and this was a small study, I think it was less than 20 patients, where they showed that thymopoietin was hypersecreted in MG patients. So they gave that to the torpedo ray, and what they found was that it binds to acetylcholine nicotinic receptors and that it worsens the neuromuscular junction function. So thymopoietin, again, could this be a hormone that could tell us that your disease is active, that you will have a severe disease, that you will go into a crisis, perhaps? So we're also looking and measuring that. IgG, I think is very important. There is a lot of data actually showing that IgG1 and IgG3 are elevated in patients with myasthenia gravis. So they have increased synthesis and increased production of it. It's not broken down as well, and so you develop this immune dysfunction. It's really important to note that IgG1 is one of the main ways the antibodies or the antibody types are, a lot of them are primarily IgG1 subtype. So again, having an elevation in this marker or substance IgG1 and IgG3, could that be a biomarker telling us, yes, there's a disease present? Zinc, I briefly mentioned, and it's much more complex than what this slide shows, but suffice to say that without normal levels of zinc in your body, and zinc and copper go hand in hand. When zinc goes up, copper goes down. When copper goes up, zinc goes down. So something we don't routinely do, but that I'm doing in my patients and trying to study a little bit better about what their zinc levels are at the time of presentation and when they go into a crisis. Because my feeling is that they're altered, that it's reduced. Zinc, as I said, works directly with thymulin. Without zinc, thymulin won't function, but it does have other effects on the thymus and the bone marrow as far as being able to produce T cells that are very healthy and able to ward off infections or ward off autoimmune disorders. Interleukin-2, which is also a main player in the game of maintaining a nice balance in your immune system between pro-inflammatory and anti-inflammatory, is very important. Normally, you'll find that interleukin-2 allows there to be this balance of cells. And these are the three cells that I've talked to a little bit about. The T regulatory cell, which helps maintain a balance in the immune system. The CD4 and CD8 cells, these are officers, if you will. When your body has an immune response, so when, let's say, one of these T cells sees the myeloid cell and it becomes angry, it becomes frustrated, if you will, that, hey, I don't recognize you, and all of a sudden you've got this immune response taking place, this is what happens. And interleukin-2 is actually very key in allowing this to happen. So what you see here in this cartoon is this massive, proliferation and development, if you will, of the lymphocytes. And also, not only are they developing and multiplying, but they're maturing and becoming a certain type of cell that recognizes certain other parts of the immune system that would allow you to ward off MG, if you will. So I think interleukin-2 may be another biomarker to look at. Interleukin-6, likewise, it is very busy, if you will. It does a lot of things in our bodies, but from our standpoint, the important thing is that it has a direct effect on B cells, and B cells, if you recall, are the cells that produce antibody, and it also has a direct effect on these immature cells that are coming from the bone marrow, the T cells, on their way to the thymus gland, and it has, an effect on making them more specialized and becoming T regulatory cells that allow the balance. So again, interleukin-6 is another player and another substance, a cytokine, if you will, that I think is going to be important as a biomarker in MG. Sleep. We heard our last speaker, for those of you that were here, talk about the importance of sleep on MG, and we've all heard the advice doctors give, please be sure that you get plenty of rest, and it's not only resting, but sleeping. Well, as it turns out, sleep not only allows our bodies to rest, but while we're resting, there's a lot going on in the immune system. In fact, sleep, as you've probably heard, is not necessarily restful. It may feel restful to us, but it's sort of a recharge, and it allows our brain to sort of reset, to reboot in many ways. So one of the things that we know happens while we sleep is that there is a increase in the substances that have to do with pro-inflammation that are able to fight off MG in many ways, if you will. And there is a drop in substances that would allow us to develop MG. So by having sleep deprivation, then there is that loss of balance. All of a sudden, we have too much of the cells or the substances that are going to give us MG or allow MG to perpetuate, and we don't have enough of those substances that allow us to ward off MG. So one of the things that we're looking at as a biomarker is the number of hours that you sleep, when you go to sleep, because sleep is very complex. There's a circadian rhythm to them. There's a pattern. And those of you who have ever done night shift work know that if you're working at night and going to sleep at day, things change in you. And so these hormone changes are some of the things that take place as well. So sleep becomes very crucial, I think, to patients with MG. And I think it's important that we educate you to be able to get your 8 to 9 hours. In the real world, it's very hard for us to get that, especially if you have a family and you work, but that's something that you should all be striving for. And so one of the reasons that biomarkers, and I'm almost done here with my talk, is so important from a clinical standpoint, not only because, biomarkers would help us help you better, but with MG, this is sort of what happens at the very end. So this is a normal neuromuscular junction. This is the nerve. This is the muscle. As you can see here, a nerve impulse travels down this nerve at the bouton, and it releases acetylcholine. Acetylcholine is attached to these blue little receptors here, and eventually you get a muscle contraction, and that's normal. With MG, as time goes on, these are the changes that you see. So yes, you still have release of acetylcholine, but now look at what's happening. You have that acetylcholine can't attach to the receptor here, so you've got blockage, and these are IgG molecules. But it's not only that this is blocked so that you can't get that information from the nerve to the muscle, if you will. You have lost the surface area. Look here how much, and there would be receptors all along here. All of a sudden you're down to this. And then more importantly, the distance that the acetylcholine has to travel from here to here is larger. It takes them longer to get. So your disease progresses. And as the disease progresses, these changes, and we don't know when this happens, but this may be a time when you all of a sudden become refractory to treatment, and no matter what we give you, no matter what we do, no matter how good you are, you're doing everything right, you're seeing the best doctors, and you're still not getting better. And so for most of us who treat MG patients, this is what we try to prevent. And with the biomarkers that we're looking at, we're trying to evaluate when this happens so that we can prevent it. We're looking for markers that tell us, hey, this is about to happen. Because once you get to this point, it's very difficult to treat you. And I think many of the people that have this are people who've had MG lifelong. So we're talking about the kids, the 5-year-olds, the 10-year-olds, when they get to be 50 and 60, we just can't do much for them, at least not now. So the purpose of the biomarker study, to summarize, is to identify markers that will tell us what therapies work and which ones are best for each and every one of you. So as you heard at the introduction of the talk, it'd be wonderful if you came into my office and I said, Mrs. X, let me test your blood. Oh, I found factor Y, let's say thymulin, and thymulin is elevated, so it tells me that you're going to respond to treatment Z. That'd be wonderful, because then you would not have to go through all of these therapies that may not work for you, that are expensive, and that put you at risk for other things down the road. And if you developed MG when you were older, in many ways it's a little bit easier than when you are 20 and starting off with your life, because you have these side effects like weight gain and acne and all sorts of things, even infertility, that really affect you. So I think it's really important that we be able to personalize your therapy. Just like we're doing this with cancer, with lung cancer, breast cancer, et cetera. One day we hope to be able to come to you and say, hey, this is your treatment, and that's what you're going to improve with. It allows us to look for other therapies. It's going to help us understand a little bit better about what's going on in myasthenia gravis, and both when you're in remission and when you're having an exacerbation or crises. We're hoping to learn what will prevent the progression of the disease. We're looking for factors that actually lead to progression of disease. We're going to look at patients who will go into a crisis versus those that don't. And again, that is so key. If we can prevent one patient from going into a crisis, I think we've made a lot of progress. And then a question that I think is sort of very difficult to explain at times is what really is chronic myasthenia versus acute. Acute might be something, well, it's the first time you're there, you're having some weakness, we're going to treat you, but it can also be you've been doing great for many years, and then all of a sudden, boom, you come in, I can't swallow, I can't speak, I'm seeing double. So it's an acute sort of change, if you will. So we're going to be looking at what is acute versus chronic, and again, hoping to tailor therapies more sort of productive and those that will work for you. We're going to be looking at all of these factors. We're looking to separate those that are seropositive versus those that are seronegative. We're going to be looking at all the different types of antibodies out there, including LRP4, anti-titin, striational antibodies, et cetera. We're going to be looking at the age of onset, early versus older, where you start. So one of the things that we know is that the eyes are one of the more common sort of muscles that are affected in MG. We know that it has a very high amount of fetal acetylcholine receptor still present, and so we're going to try to identify what parts of the acetylcholine receptor and possibly what is going on in your muscle at the onset that when you come in with that particular type of weakness. We're going to be looking at how long it takes for you to start your therapy. We're going to be looking at patients who've had thymectomy, and then we're going to look at some other factors. The temperature, as many of you have observed, when you go into warmer climates or when it's very humid, boom, your MG just worsens. In colder climates, you turn to do better. But we don't know exactly what the drop-off is. We don't know if there's a particular internal temperature as opposed to an external temperature that causes this change. Sleep cycle is something, the labs that I mentioned, the thymulins. And then last but not least, we're going to be looking and analyzing your repetitive nerve stimulation studies to see if at the time that you were diagnosed, there was something specific with in the study that told us, hey, you're going to develop an exacerbation or you're going to go into a crisis, et cetera. So there are various stages to this study, and right now we're just sort of in the process of getting started, where we're starting to draw blood samples. We've been analyzing charts and doing family histories now for several years. We've got that information, and we're ready to go and start looking at different markers or substances that I mentioned, like interleukin-2, thymulin, et cetera, zinc. We're also ready to go ahead and start doing genomic sequencing on some of the patients. We are trying to find patients where it does seem to run in families. And then last but not least, hopefully we'll have biomarkers over the next few years that will eventually lead to personalized therapy. So with that, I want to conclude. This is a picture of Baylor College of Medicine. It's actually away from our medical center now. It used to be right in the midst of it, but we've gotten away from it. And it's really beautiful campus. We're also having a company that does a lot of biomedical engineering and biomarker research be developed on the campus close by. I want to thank my research team. And then last but not least, I have a very special gratitude to Jocelyn and Brian Macbeth, that without their support, I would not be able to do the research. The Houston MG support group, also likewise, without their support, I don't think I'd be here today. And then last but not least, all of my MG patients, they are amazing. They keep me going, and I'm sure your doctors feel the same way about you. You guys are just go-getters and don't let anything kind of interfere.